Hey guys, this is Eric back with you with FlightBridgeED. I wanted to take about 15-20 minutes today and talk about just a simple patient presentation as it relates to DKA. And I think this is a real complex type of patient. I think it's good to review different aspects of DKA and how we're going to manage them, because I think there's a lot of things that we can do right and wrong to affect our patient's clinical course in a positive or negative way. So let's start off with just a simple patient scenario regarding that, and then we'll talk about maybe some treatments, different ways to approach that patient. Obviously, with medicine, we can approach patients in different ways, and this isn't going to be a hard and fast rule in some instances. So let's say we have a 30-year-old male patient that comes into a small ER, and he was transported by ground EMS. Ground EMS found him. He'd been down per family about 2 days, and through this time, obviously, he had no fluid intake. He had excessive urine output. He was found semi-conscious with a GCS of 10, and let's say he's vomited times 2 for EMS. He was found with some dry vomitus on his mouth. You get them to this small facility, you have an IV established, and they haven't really been very aggressive with any treatments at this point. For purposes of this presentation, let's say we'll give him some labs. We'll say his sodium is 138, his chloride is 95, so he's a little bit low on his chloride, and we'll say his potassium is 2.3. Blood gases we'll throw out there. He's got a pH of 7.0. He's got a bicarb of 15, he's got a PCO2 of 20, and he's got a PO2 of 85. So he's oxygenating fine. And so you arrive on scene for this transfer, and you find him having Kussmaul respirations. He's breathing about 36 to 40 times a minute. He's semi-conscious to painful stimuli, just kind of moans and groans. And you have about an hour flight to your receiving facility. So how are we going to manage this patient? The first thing we want to, I think, look at is if we can identify any other aspects of his history. Is this a concurrent problem? Is he a very non-compliant diabetic, and things like that? And so obviously a good patient assessment, listen to lung sounds, identify if he's possibly aspirated and things like that. Can he maintain his own airway? Remember, in a DKA patient, we want to allow them to maintain their own airway as long as possible. They're compensating, and we don't want to knock that compensatory mechanism down. We want to make sure that they continually blow off that CO2 to try to overcome that metabolic acidosis. So whatever we can do to augment that and assist in that. Then the decision kind of lies, well, he's already aspirated, or can he protect his airway on his own? He's vomiting and things like that. So what can we do to maybe help him along? And are we going to perform an RSI on him based on that he's already aspirated or he's actively vomiting? And I think you could approach that in two different ways. I think some clinicians may say, you know what, he's already aspirated. He's not going to do any more damage. He's probably already going to have a pneumonitis, and so we're really not doing any more harm by allowing him to continually maintain his own airway. And then you have the other clinician that may say, you know what, I'm not going to add to his condition, and I'm going to manage his airway aggressively. I'm going to RSI him. I'm going to try to attempt to maintain that compensatory mechanism by matching that on the ventilator. But I want to protect that airway. And I don't think that there's a right or wrong answer there. I think there's positives and negatives to each one. So let's talk about each one really quickly. If you go the route of non-intubating and allowing him to blow off that CO2, I think that that's probably the safest thing to do. And I think that there's a pretty strong argument out there to say that, he's already aspirated, you're not going to make him worse. What's going to make him worse is by underventilating him, not matching that compensatory rate, and dropping that pH. Remember from earlier podcasts when we started talking about acid-base balance, you have a correlation between pH and PCO2, and that correlation is for every 10 points you increase in PCO2, you're going to drop your pH by 0.08. So if you hypoventilated your patient, and if you performed an IRSI and you had difficulty intubating the patient, you didn't match that rate, and their CO2 shot up, let's say 20 points, you're going to have a reduction in pH by 0.16, and so you're going to be down into the 6.8 range really quickly. We know that if you have a pH that drops any lower than that, you could put them into a brady arrest, heart blocks, things like that, and you're going to cause them to code and die on you. So in that aspect, I think there's a strong argument to say that it's going to be safer to allow them to compensate, to continually blow off that CO2, and allow them to do that. On the other hand, we're also taught to always manage somebody's airway, that airway is number one, and if they're vomiting and can't maintain their own airway, we need to take over. And so I think there's also an argument for that. And if you're going to choose that route, if their GCS is to a point where they can't clear their own airway, and you're going to have problems, especially in the industry of helicopter EMS, I think you need to be planning ahead. And when you perform your RSI, there may be an argument to say, I'm going to give him his fentanyl. We're going to give him a fentanyl dose, sedative pain management dose of fentanyl prior to intubation. Going to give him his etomidate. We're going to have our ventilator set up prior to this, have it on SIMV, and only utilize just enough medications to elicit intubation and not knock them all the way down. Don't paralyze them. Don't do anything like that. Okay. So at this point, we're just talking about airway management. We haven't even gotten into the whole process of correcting the pH, correcting the severe acidosis, worrying about the potassium and things like that, and dropping the sugar. So as far as airway management goes, if you're going to do that, make sure the most experienced clinician is performing the RSI. Only use enough medications to pass the tube, and allow him to breathe over the ventilator once you have him on the ventilator. If you still have him knocked down to a point where he doesn't have much respiratory drive, make sure that you match whatever his compensatory rate was prior to you intubating him. Match that rate on the ventilator. So put him on SIMV, put him on a tidal volume that's physiologic, like we learned, anywhere from 6 to 8 mils per kilogram. I would start low, and then match his rate. Put his rate at 34, 36 a minute, and maintain that, right? That's what he needs, okay? All right, so we've talked about managing the airway. Now we have some other problems. He's dry, right? His potassium is 2.3. That's critically low. And remember, in metabolic acidosis, you're going to have a falsely elevated potassium as it is. So not only is it low because he's just washed it all out, he's peed it all off, but now it's falsely high, and it still is low, if you get my drift. So his potassium could be 1.9, right? There's also a correlation of pH and potassium too. So if we start correcting his pH and we don't account for his potassium, your potassium is going to drop. And so the correlation is if you increase the pH by 0.10, so we started at 7.0 on our pH, and let's say our pH goes up to 7.1, your potassium is going to drop by 0.06. So now we're down into the 1.3, 1.4 range, and you're going to also probably kill your patient by doing that. The other aspect of treating DKA is they need a massive amounts of fluid volume, fluid resuscitation. And with that, if you start adding all this fluid on them, you're going to dilute that potassium even more. You're going to wash that out. So we have to be treating the potassium. You can never raise potassium very quickly. It's a slow process. So if you're going to start that fluid resuscitation, which is what we need to do in DKA, you need to make sure you're adding potassium. Give him runs of 20 of K, piggyback that with a potassium, in your fluid. If you have the ability to put an NG tube down this patient, which I would probably advocate, being that he's vomiting, you could put it through the NG tube and do it that way. But he's going to need continuous runs of 20 of K consistently throughout the flight. Obviously, we don't carry that. Most flight programs don't carry potassium, so this is something you're going to have to ask the referring physician if you can, take some with you or start it prior to your transfer. This is extremely critical in this patient with a low potassium like this, because he needs volume, he needs tons of fluid, but you can't give him all that fluid without adding potassium to his maintenance infusion. And then the other aspect of this is how aggressive are you going to be with treating this metabolic acidosis? This is a brittle patient. You have a high sugar, and so let's say his sugar for this patient is 600. You need to identify where this patient normally runs, and is a 600 sugar excessively high for him, or is it just a little bit high? You may start treating that sugar in a hospital setting and get him down to the 400 range, and he may become very conscious, alert, and very comfortable at that range. So I think in the helicopter EMS setting, treating his sugar, I guess there's arguments for and against. If you start treating his sugar and giving him insulin, again, we don't carry insulin drips. You would have to get that from the referring facility and start treating the sugar. Most DKA protocols in ICUs are you're going to do this very slow. You're going to need to monitor the sugar hourly and do this. So I think for me, the argument is I'm probably not going to really worry about giving the insulin and worrying about the sugar at this point. I would want to maintain his airway. I would want to start the volume resuscitation, adding potassium, getting his potassium up, and just trying to correct the metabolic acidosis, and then worry about the sugar when he gets to the facility that you're transferring him to. You start giving insulin, you start doing that, then you're going to have more potassium shifts, and that's going to drop the potassium even more. So we really need to be very, very careful. And I think in our setting, we don't have the capabilities. We don't have iStat machines. We don't have those things. Maybe some programs do. Most programs don't have those capabilities where you can monitor a blood gas. You can monitor those labs that are critical in this patient to identify if you're having a positive or negative change. So I think for this patient, the best treatment is going to be maintaining a good airway, whether you decide to allow him to maintain his own airway and continue to blow off that CO2, or if you decide to RSI him, use just a minimal amount of drugs to elicit intubation, match the ventilatory rate that he was on or she was on prior to intubation. Make sure you maintain that so you don't have a precipitous drop in pH. Then start your volume resuscitation. Add potassium immediately onto that. Get permission, and start from there. And then worry about the sugar later on. So this can be a very critical patient for you. It could go very bad if you don't worry about these things. And so in this patient, if you start treating this patient without knowing what their labs are, without knowing their potassium, and getting a good idea of what their blood gases are, you could really be treating blind, is what I would say. Obviously with the blood gases, we could kind of automatically assume that they're poor, that they're very critical, but the potassium to me is the big factor here. And a low potassium is a bad thing. You can't correct that quickly enough. So that's a big thing that I would make sure I had before I left the facility. Or, I wouldn't be giving a lot of volume at this point. So with these patients, just remember to look at the big picture. Try to get a good history. Think about every aspect of the treatment modality for this patient. Airway, the blood gases, how that affects changes as far as CO2 and pH, and the relationship between potassium and pH. How you can affect that positively and negatively, and then look at the overall treatment as it relates to fluid resuscitation and what that's going to do to your potassium. Make sure you're adding potassium on it, whether you're giving it IV or you're giving it through an NG or OG tube is up to you. And just really watch your patient and make sure if you're going to utilize the ventilator, you're matching that rate, and help them compensate, and I think you'll have a good outcome with your patient. So that's all I have for this podcast. We want to thank everybody so much for the support, for listening to our podcast. Remember, you can subscribe to iTunes. It's free, and you can download the free podcast app on iTunes and just subscribe to FlightBridgeED. And I believe if you just search the FlightBridgeED Podcast, it'll come up, and all of these podcasts will automatically download to your phone. Or you can go to the website again, and you can listen via the website MP3 format. If you're interested in any CFRN or FPC review classes, we're willing to come to your location, your facility, your agency. Just email myself, Eric at FlightBridgeED.com, and we'll definitely set that up. So thank you so much again for the support, and we'll talk to you next week with a new podcast.